So welcome everyone. Thank you for joining us for the Tuesday lunch with RITA webinar on IgA Vasculitis. I'm really happy to co-chair this session with Giorgio Trivoli. Briefly, I'm Professor Alexandra Audemard Verger from France. I'm a senior lecturer in vasculitis. I'm working in the departments of clinical immunology, and I've been working in IgAV in adults for about 10 years. Recently, we have set up a group, a European working group, in order to draft position statement in order to improve care of patients with IgAV. Please feel free to use the chat to let us know where you're joining us from. We want this session to be interactive, so please feel free to ask the question tab, which you will find on the right-hand side of your screen to ask question at any time during the presentation and during the question and answer sessions that will follow. So now it's the time to introduce Giorgio.
Morning, everyone. So my name is Giorgio Trivoli. I'm trained as a nephrologist in Florence, Italy. I'm now fellow in vasculitis and nephrology in Cambridge. And I'm going to introduce our first speaker of the day, who is Professor Augusto Vaglio. He is professor of nephrology at the University of Florence and works as a nephrologist in the Mayo Children's Hospital. His research interests are broad and include ANCA vasculitis, eosinophilic granulomatosis with polyangiitis, IgG4 related disease, Adam-Chester disease, many other things, including IgA vasculitis. He is now co-chairing with Alexandra Audemard Verger the European project on guidelines for IgA vasculitis in adults. And so we will invite him to give us a talk about IgA vasculitis, and mainly he will cover adult aspects, I think. So please, Augusto, thank you for joining us.
Thanks everyone, and it's a pleasure for me to deliver this talk and to be helped by Louise Oni, who will cover the children part, and I will provide a sort of introduction on the disease and on the main issues in adults. And I would first of all, I would like to thank Giorgio and Alexandra for introducing me, and especially I'd like to thank them because my knowledge and my experience with this disease has grown thanks to the a work that I'm coordinating with Giorgio, which is on rituximab in IgA vasculitis, and also, and I would say especially for this large initiative that Alexandra and I are coordinating within the European IgA vasculitis study group for the development of guidelines, which is challenging because there's no, you know, the amount of data on IgA vasculitis in adults is quite limited. But it's of course a large committee, the one that we gathered, and this is therefore a source of information, a source of experience. So what I will tell you today is something that derives from the literature and from this kind of experience that has grown in the last few years. So if you allow me to share my screen. Okay. Should be sharing now. Can anyone confirm?
Perfect.
Okay. So my presentation today, I think I have about 20 minutes. I'll try to be on time. We'll touch on three main aspects of the disease: the clinical presentation of IgA vasculitis with a focus on adult onset disease, some pathogenic aspects, particularly genetics and triggering factors, and then an outline of treatment. The disease is mainly a pediatric disease, and about 90% of cases are pediatric, and the peak incidence is around 4 to 6 years of age. Whereas if we consider adults, it's generally middle-aged subjects that are more affected. The male to female ratio is about 1.5, so it's slightly more prevalent in men. And there's a large variability in the proportion of patients who develop renal disease. It has estimated that this is around 30 to 40% in children, and it's slightly greater in adults. We do not have true diagnostic criteria. We have different sets of classification criteria. The first dates back to 1990, when the American College of Rheumatology developed the classification criteria for the main vasculitic syndromes. But this is no longer used, I would say. I mean, it's I think it lacks sensitivity and also some degree of specificity, and it's not been validated in large cohorts, especially in adults. Whereas we have more recently the EULAR classification criteria for children, and this was shared also with the Pediatric Rheumatology Society, the European Society of Pediatric Rheumatology, and the PRINTO organization. And these criteria are mainly used in children and are thought to be used in children because they start with a mandatory criterion, which is the presence of purpura with lower limb predominance, and one or more of the criteria that are listed here, like abdominal pain, arthritis, arthralgia, kidney disease, or leukocytoclastic vasculitis with predominant IgA deposition in the skin, or proliferative glomerulonephritis with predominant IgA deposits, if we consider kidney biopsies. These criteria have of course, they have by definition a high sensitivity because they capture all patients with palpable purpura and one of these other manifestations, but the specificity is low. I mean, it's not as high as the sensitivity, but this is acceptable. The problem is that this is mainly for children, but there's a recent study by Cesar Ozen who applied these criteria in adults, and from a preliminary analysis, it appears that they work well in adults if you exclude other diagnoses upfront, like cryo or ANCA-associated vasculitis. And this is also understandable, I think, because if you think of a patient with purpura and arthritis, and this is a child, this is very likely to be IgA vasculitis, whereas a patient with purpura and arthritis and also other vasculitic manifestations in adults, it's less likely to be IgA vasculitis. It's more likely to be, I don't know, a drug-induced disease or an ANCA-associated vasculitis or a cryo. So if we want to apply this classification criteria in adults, I think it's mandatory to exclude other diagnoses first. And in adults especially, we need a biopsy. And we need a biopsy just because the mimics of IgA vasculitis from a clinical standpoint are so many. So we need a biopsy to demonstrate that the deposition of immunoglobulins is dominated by IgA. And this happens at the skin level, where the typical histological manifestation of the disease is leukocytoclastic vasculitis. And we can find IgA deposition in the skin, although this is not the rule. Whereas it's, I would say that the proportion of patients with a compatible kidney biopsy who have IgA deposition is higher. So if you perform a kidney biopsy in a patient with IgA vasculitis in an adult patient, you're very likely to find IgA deposition in the mesangium. Whereas if you take a skin biopsy, these might be negative. Anyway, I think And we as a group think that in adults it is mandatory to have a biopsy, or it's highly recommended. At the same time, in adults, we have to rule out as much as we can secondary forms of the disease, like those secondary or associated with liver disease, inflammatory bowel disease, the use of drugs, the presence of underlying malignancies and other autoimmune disorders. The disease has several different manifestations, and let's start with the purpura. This is usually more prominent below the waist. There's usually a sparing of the upper part of the body, of the face especially. These purpuric lesions, they're usually they're palpable, and they can become ulcerative, particularly in adults. And as I said before, the biopsy of these lesions usually shows, or I would say very frequently shows, leukocytoclastic vasculitis. There can be arthralgia, or in many patients we also have true arthritis. This is often migratory, it's non-erosive, it's usually, it involves multiple joints. Gastrointestinal disease is very common, although most of the times it's a sort of non-specific abdominal pain, but there can be a very, even life-threatening gastrointestinal manifestations such as bleeding, bowel ischemia, intussusception, and perforation. And then glomerulonephritis, which is approximately which affects approximately 50% of the patients. It may arise also weeks after the rash. This is what we see generally in children, but it happens in adults as well. And the clinical manifestations range from microscopic to macroscopic hematuria, and there can be also some exacerbations of the disease when there are infections or infectious processes, especially involving the respiratory tract. This is an example of palpable purpura. This is typical. You can see this is a child with purpura and arthritis, so you can, make a diagnosis even at looking at this patient. These are CT scans showing bowel ischemia or edema. You can see the thickened wall of this bowel tract, and this is a case of intussusception, which is something very, frightening for us as clinicians, and it is one of the complications of the disease. And actually, if you look inside, this is an endoscopic image. You can see that the purpura in the gut is more or less similar to what we see on the skin. If we compare, but this is not, this is not the focus. The comparison between children and adults is not really the focus of my talk, but I would just like you to have a look at these plots. And these histograms, especially when you consider the fully established disease, clearly shows that the manifestations of the disease in terms of proportion of patients presenting with these manifestations are quite similar when it comes to skin, gastrointestinal, joints, and systemic symptoms. But the main difference is in terms of proportion of patients suffering from renal disease. You can see that about 30% of patients with a childhood onset disease have kidney involvement, whereas about 80% of adult patients have a kidney involvement. This is a large study, and this is the French series coordinated by Alexandra, and it includes 260 patients with adult onset IgA vasculitis. You can see that the mean age at diagnosis is about 50 years. Skin symptoms are almost invariably present, and you can see also that the proportion of patients with necrotic skin lesions is quite high, is about 25%. Joint involvement is very common, gastrointestinal disease as well, and this is a main difference with other systemic vasculitides. For instance, peripheral neuropathy or alveolar hemorrhage, which are common manifestations of ANCA vasculitis, for instance, they're quite rare in patients with IgA vasculitis. This is a main difference. So you can, consider these manifestations when you do the differential diagnosis between IgA vasculitis and ANCA vasculitis, which is not easy from a purely clinical point of view. And you can also see that the proportion of patients with an eGFR at the time of diagnosis below 60 is considerable, is about 30%. If we perform a kidney biopsy in a patient with IgA vasculitis, in an adult patient with IgA vasculitis, there's a range of histological manifestations that we can find. And these manifestations range from purely mesangial proliferative glomerulonephritis, which is absolutely similar to what we see in IgA nephropathy, so in the kidney-limited form of IgA nephropathy. But the other end of the spectrum is what you see in this picture on the right-hand side of the slide, which is a necrotizing crescentic glomerulonephritis, which is sometimes indistinguishable from what we see in other rapidly progressive glomerulonephritis. It is quite often assumed that the histological manifestations of IgA nephropathy are the same that we find in patients with IgA vasculitis. This is not entirely true. You can see in this table, which summarizes histological manifestations, that, for instance, crescents tend to be more frequent in patients with IgA vasculitis-related nephritis. And this is also true for necrosis, for neutrophil infiltration, which is much more frequent, I would say, in IgA vasculitis nephritis than in IgA nephropathy. And then crescents also tend to be circumferential in IgA vasculitis, while they are usually segmental in IgA nephropathy. This is not the rule. Again, this is common. And especially when we look at immunofluorescence or electron microscopy, we will find that subendothelial deposition is much more frequent in patients with IgA vasculitis-related nephritis. Not only the frequency of of kidney involvement is higher, but also the severity. And this is one, this is the leitmotif of IgA vasculitis in adults. It's a more severe disease, especially when we consider renal disease. This is a study by Alan Salama and his group. It's a UK cohort of patients. It's a large cohort, again, more than 200 cases. And you can see that there are a number of patients whose biopsy shows crescents, so crescentic proliferation, extracapillary proliferation. And there is a huge variability in terms of proportion of chronic damage, mild to severe chronic damage. And this study, similarly to the one that I will show you next from the French cohort, divides patients into age groups, and you can also see that there are differences. And these differences are somehow expected because you know that there's a physiological decline in kidney function in patients with age. But I would say that if you look at the eGFR, especially of patients with an age range of 18 to 34 years, and you compare to the eGFR of patients older than 60 years, this is incredibly different. And the main conclusion of the study by Alan and colleagues is that probably the disease is extremely more aggressive at the beginning, and so this very strong hit that IgA vasculitis has on the kidney is just there. And then the progression of the disease is somehow parallel between these age ranges. This is the kidney outcome analysis by Alexandra and her group and on the French vasculitis cohort of patients with IgAV. And again, you can see that if you divide by age range, if you separate patients into age groups, there's a huge difference in terms of eGFR, especially at last follow-up. So the first analysis clearly shows that the difference is mainly at the beginning and maintains over time. And this analysis by Alexandra shows that the outcome is clearly different. Anyway, overall, the bottom line is that these patients have a very high risk of developing chronic kidney disease and sometimes end-stage kidney disease. which are the main predictors of chronic kidney disease, or in this case, what are the predictors of end-stage kidney disease? This is, again, the UK study, which showed that not only the age, but also the gender, in terms of, male are at higher risk than female. The ethnicity matters a lot, because Black patients are at a higher risk, and this is probably related to the genetic background with the ApoL1 status, which predisposes to a higher degree of, a more rapid progression of several kinds of glomerular diseases or renal diseases in general. And of course, there are other predictors, like the presence of an eGFR lower than 30, like the presence of chronic damage. This is a very interesting study performed by a multinational group, and this lumps together children and adults. The cohort comprises about 300 patients, 200, more or less 200 children and 100 adults. And this is a sort of sort of cluster analysis, which is performed using the latent class mixed models, meaning that all the patients are put together and then they are clustered based on their outcomes. And you can clearly see that the profile of these patients has two subgroups. One is a subgroup where there's no big change in kidney disease over time. And the other subgroup starts with a lower eGFR, tends to recover or to probably hyperfiltrate in the second phase, and then accumulates damage, and the progression towards end-stage kidney disease is higher. And interestingly, these patients are the ones that show on biopsy E1 on the MESC score, meaning that they have more endocapillary hypercellularity. They tend to have a more systemic disease, and they tend to have a lower baseline, as we saw, and they tend to be male. So this is a subgroup. And this plot, I think, is very interesting also because it shows that if you have damage at the beginning, even if you tend to recover in the second phase, you have a third phase where this initial damage, has an impact on outcome. The disease has no clear pathogenic mechanisms. It is really, I think it's a sort of tradition from the literature in this field that the pathogenesis of IgA vasculitis is quite the same as the one of IgA nephropathy. So the hypothesis in IgA nephropathy is that we have IgA, they have a defect in glycosylation, in galactosylation in particular, so they become immunogenic. So autoantibodies of IgA or IgG subtype are produced against the hypergalactosylated IgA. They form immune complexes. These immune complexes tend to deposit in the mesangium in the kidney or in the blood vessels in the skin or in other organs, and there they elicit a cellular response. But I think, and also some studies, even Alexandra performed some studies on NK cells, on T cells and other cell types, demonstrate that actually this is more a vasculitis. IgA vasculitis is actually a vasculitis, even from an immunological point of view. So there are differences with, as compared with IgA nephropathy. And I think we can consider this disease as a truly complex disease, where complex disease means that genetic susceptibility factors and environmental factors, and probably epigenetic and lifestyle factors, play a role together in shaping up the disease. This is an interesting study, and this is a very large cohort of patients with IgA vasculitis, which includes children and adults. I think the majority are children. More than 2,000 patients. It's a GWAS performed by the Columbia in New York, and this is still in a repository, so it's not fully final publication. But it's publicly available. And you can see that from the Manhattan plot of this study, there are some main peaks, so some main associations. One is expected, with HLA. But interestingly, there is also an association with the receptor for this Fc gamma, for the Fc portion of IgA. And there's also an association with an inhibitor of Fc alpha receptor signaling. So mainly, the genetic of this disease is HLA linked, but it's also linked to something. So it is around the IgA signaling pathway. There are triggering factors. These are clearly that they're easier to find, I would say, in children, because children usually have infections, especially upper respiratory tract infections, which elicit the disease, and the precipitating factors are detectable in about 50% of children, whereas in adults it's harder to find them. But we know that we have to screen for a number of diseases that can be, coexisting. They can trigger the disease. It's hard many times to establish a clearly causal role for these accompanying disease. I think the main message is that we have to screen these patients for associated diseases. First of all, IgA vasculitis has been considered a paraneoplastic disease, and this study by Aloysia Osevar, which is again on a large cohort of patients with IgA vasculitis in adult patients, demonstrated that about 7 to 7.5% of them have malignancies that can be classified as IgV related, meaning that their onset was within 3 years of the diagnosis of IgA vasculitis. Interestingly, these are mainly common malignancies, but I would say there's a strange predominance of bladder cancer. So this has to be taken into account. Other studies showed that there can be drugs. Among the drugs, I think the most interesting category is TNF inhibitors. This study, which is again from France, I believe, shows that TNF inhibitors can be triggers of the disease. But of course, TNF inhibitors are used for diseases like inflammatory bowel disease or psoriasis, which are per se associated with IgA vasculitis. So we really don't know whether it's a common predisposing background for the two diseases, or it's the effect of the TNF inhibitors. Liver disease, especially advanced liver disease, liver cirrhosis, can be a predisposing factor, and these patients usually die. The proportion of deaths is very high in this group, but they usually die of liver disease rather than of IgA vasculitis. And then there can be other factors like vaccination. This is a COVID vaccination, and again, the French group showed that the time to the onset of the disease was shorter with the second and third dose as compared to the first dose. So basically, to summarize, this is a complex disease where you have a strong genetic susceptibility, which is linked to HLA, particularly HLA class 2, and also IgA receptor and its signaling pathway. There are disease triggers, which are common in children, and these are usually infections, whereas in adults, it's difficult to say whether these are triggers or underlying conditions, and they anyway need to be screened. The presentation of the disease is more severe in adults, especially when it comes to kidney involvement, and we don't know whether this is contributed to by a stronger disease aggressiveness at the beginning, or comorbidities which predispose to progression, which is stronger in adults. The treatment of the disease really depends on the phenotype. If we have a skin-limited disease, we can use symptomatic treatment with drugs like NSAIDs or colchicine. If we have gastrointestinal involvement and this is benign, we can do symptomatic treatment or watch and wait. But if it's a severe manifestation, we have to call the surgeon. And then renal disease is certainly one of the challenges in the treatment of these patients. It's usually assumed that if we have IgA vasculitis related nephritis, and if we demonstrate that this is persistent, meaning that we have at least 3, 5, 6 months of proteinuria or a reduction in eGFR, all of these patients should be treated as if they had a chronic kidney disease, and therefore lifestyle advice, renin-angiotensin blockers, and possibly SGLT2 inhibitors should be considered. Immunosuppressive drugs are, of course, used in these patients. This is the trial from Evangeline Pilbou on cyclophosphamide. the only randomized controlled trial published so far in IgA vasculitis in adults. And this demonstrated that actually the benefit of adding cyclophosphamide to glucocorticoids is not as high as we would expect, because the outcomes in terms of eGFR and in terms of proteinuria are not different between the gray bars and the white bars, meaning that the two arms of the trial did the same in terms of outcome. Other drugs, this is the Cambridge experience with mycophenolate mofetil, which was published a couple of years ago, and this was on 13 patients. You can see that there was a high percentage of non-responders, which is 7 patients out of the 13 initial patients, and this was also confirmed not only at 6 months but also at 12 months. So the percentage of patients who did not respond to mycophenolate on top of glucocorticoids was high. Rituximab has been used. We coordinated an observational study on 22 patients with adult onset IgA vasculitis. This study was, I think, the first and the largest to consider rituximab as an option for patients with difficult to treat, relapsing or refractory adult onset IgA vasculitis with or without nephritis. And rituximab was used as any line of treatment, and we had nice results. Because the BVAS went down, the prednisone dose was very nicely reduced, and there was a stability in eGFR, and there was a decline, sharp decline in proteinuria. This is a log scale, so you can see that the difference between the beginning and the end of follow-up is high. This study had the drawback of having not so many patients with severe nephritis, so we decided to expand this cohort and to add more patients, and this is the study that is I coordinate together with Giorgio within the EUVAS and other centers, and we finally gathered 81 patients with rituximab treatment. There were mainly IgA vasculitis with systemic disease, and a few of them had a crescentic form of IgA nephropathy. And these were added also because we thought that it was worthwhile to analyze the outcomes, the differential outcomes of these subgroups. If we consider patients with non-severe nephritis, which we arbitrarily set with an eGFR above 60, you can see that the eGFR remains stable over time, over the follow-up, and the proteinuria really went down. So this confirms the findings of the first study. The proteinuria goes from 2 grams to 0.2, so the decline is very sharp and very consistent. But if we look at patients with severe nephritis, the two main subgroups, one is the ones with the patients with crescentic IgA nephropathy, and they do very bad. So you can see their outcome, the renal survival is poor. Whereas if we consider the response of patients with IgA vasculitis related nephritis and with a severe presentation, their outcome is not so bad. So the main message is that probably rituximab can be used in patients with other onset IgA vasculitis, and if they have a mild to moderate nephritis, they usually do very well. So I want to thank you for your attention, and open to answer your questions.
Thank you, Giorgio Augusto, for this wonderful talk. I propose that you pursue with another talented speaker. I'm pleased to introduce Dr. Louise Oni. She's a pediatric nephrologist. She's a senior lecturer in pediatric nephrology at the University of Liverpool in the UK. She has done a wide range of clinical and basic science research in the field of IgA. She has chaired a national working group consisting of multi-professionals to produce the first nationally endorsed UK guidelines for the management of IgA vasculitis in children. She also has joined the guidelines for adults. Louise, the screen here is yours. Louise, we can't hear you. Your phone is... You have to put on your micro. On the bottom of the screen, you have an icon with a micro.
Yep, I'm unmuted now, and I'll just share again. Sorry, it wouldn't let me do it at once. So thank you for the opportunity to represent the children in this webinar. I'm going to just go through about 15 slides and hopefully allow us some time for questions from everybody listening on the paediatric perspective for IgA vasculitis, with a focus on nephritis, which we've already heard is one of the key organs involved in this disease. So as we've heard, the clinical presentation is typically this triad of a very classical rash, which predominates on the lower legs and can expand to other areas, together with GI involvement, renal involvement, and then arthritis or arthralgia. And as mentioned, this line here shows the epidemiology of different types of vasculitides in the paediatric population, and it's by far the most common cause that we see in the paediatric population. As such, most paediatricians are very familiar with making a diagnosis of IgA vasculitis, and we have for some time now had classification criteria which really support in clinical practice and also in the research arena trying to classify patients according to differentiating them with other forms of vasculitis. We've heard nicely the differences between the presentation in children and adults, and you can see here that actually the organs that are involved are very similar across the ages. We do see more testicular and orchiditis involvement in the young boys than is reported in the adult population. But what we do see, importantly, is differences in the percentage of patients who might have the differing features, and that is in particular the nephritis, which Augusto touched on. And across the ages, the renal involvement is the long-term serious consequence from this condition. So we've also heard a bit about the pathophysiology and this kind of multi-hit hypothesis that it's likely to be a genetic predisposition in an individual. They then have some kind of environmental trigger, like many of the autoimmune conditions. And in the children, that's often the mucosal contact, and perhaps in adults, it might be more GI contact. But we know that IgA is the first line of defense in your mucosal secretions. And so it's likely to be triggered by anything that's activating your immune system in the kind of oropharynx or also the GI tract. We then see this cascade of autoantibodies, T cell, B cells, and activation of many of the inflammatory pathways that are shared with other forms of autoimmune disease, like the complement pathway, and activation of neutrophils and also cytokine production. But as mentioned, we classically know that these galactose deficient versions of IgA1 are produced, and this is thought to be the initial kind of area that can activate the autoantibodies against this region, and it's particularly the hinge region of IgA1 where we see the abnormal glycosylation. And that's very similar to what's seen in IgA nephropathy. And we see then circulating immune complexes, and within the kidney specifically, but also in the skin and the other organs, we see a deposition of these immune complexes, and then that whole inflammatory cascade that I mentioned on an organ basis. So as I touched on, there are environmental triggers. Augusto's talked about kind of the viral or infection and also cancer triggers that might be seen across the ages. But one thing that's worth bearing in mind is that there is recognition that some of these environmental triggers might be to do with the wider environment that we live in. And this paper here looked at rare diseases as a whole in over 25,000 adults and children, and saw that actually if you're a child with a rare kidney disease, you are more likely to live in a deprived region. And so there's something about the socioeconomic status and the environment of that status that might also be a trigger for some of the rare kidney diseases. And we looked on a more local level at 200 children who were recruited to the IgA vasculitis study, and we looked at the distribution with their index of multiple deprivation, and we also saw clustering of the disease in areas where there was much more severe deprivation. So there may be some environmental triggers that are to do with the socioeconomic status of the region that are far beyond those that are more classically seen with medical illnesses. And this is also shared with IgA nephropathy, where they also saw levels of socioeconomic deprivation were associated with a worse kidney outcome. And so there's this common theme of the wider environment that we live in that could be a trigger for these autoimmune conditions, particularly IgA-mediated disease. So as we heard, nephritis is the biggest contributor to morbidity in all of the ages, and these were national recommendations, but there's now international guidelines for childhood IgA vasculitis, and it's recommended that at least 6 months of monitoring for all children who present with IgA vasculitis should be performed, and this should be regular urinalysis with a minimum of a urine dipstick performed approximately weekly for the first 4 to 6 weeks, and then could move monthly if it's normal thereafter. And this is based on best evidence, but it's limited evidence, as you can see with the scoring here of 1B. And what we have seen in 2 publications is that actually if your urine is normal at day 7 and your disease is resolved, you're very unlikely to have any renal comorbidity. So there may be further rationalising of this screening that we might be able to do in the paediatric population. But we also heard that it's a common cause of end-stage kidney disease in the children. 1 to 2% of all patients when they present will progress to end-stage kidney disease despite the current treatments. And it's the second most common reason to do a kidney biopsy in the paediatric nephrology setting. We also heard that the adults are at much greater risk of this end-stage kidney disease, and you see here this comparator paper where it looked at 48 adults and 112 children, and you can see that the complete recovery was seen in 70% of the children, but only 41% of the adults, and we saw much more comorbidity with 10% progressing to kidney failure and only almost 2% in the paediatric population. But across the ages, we see the risk of kidney failure increasing with those adverse baseline features, like Augusto mentioned with the crescentric biopsy, but also heavy proteinuria and a low GFR at presentation. And so there are a subgroup population who are at even higher risk. And if you get that subgroup, about 20% will progress to kidney failure. So how common is nephritis in the children? The reported rates in unselected cohorts, there are many papers out there that have just looked at those who've had a kidney biopsy or those who already have established evidence of early nephritis. But if you select out the 24 studies globally on the unselected cohorts of all children when they first present, we found the overall incidence of nephritis was just almost 30%. And we didn't see significant difference across the world. But what you do see is significant publication bias, with the majority of these unselected cohorts coming from certain regions. And what we see then is limitations in the publication and the cohorts that are being reported within the literature that are then being used to inform the guidelines, which is worth bearing in mind. So when to treat, we know from a Cochrane review and from a few clinical trials that the use of early steroids in all patients when they first present with IgA vasculitis, regardless of kidney involvement or not, does not prevent the onset of nephritis. So there isn't a role for giving everybody a course of steroids to try and prevent nephritis. The current treatment focuses on patients who have evidence of nephritis, typically those who have biopsy-proven nephritis. And there are biopsy indications that have now been published in the paediatric guidelines. You'll see here from the IPNA guidelines that they looked at biopsy indications just in this top panel, and they looked at different thresholds for proteinuria and different thresholds for GFR. Although most children will maintain a normal GFR in this condition, it's usually proteinuria that is their presenting feature. We then saw that they would classify them according to the histological features, and this would then direct treatment according to whether they were kind of in the milder, moderate or more severe category. And these guidelines are available, so I'm not going to go through them in significant detail, apart from to highlight if there isn't remission, I think there is a significant role for repeat kidney biopsy to look for evidence of ongoing disease, inflammation and activity, which might warrant further treatment, or actually whether you're dealing with a chronic disease, which might then need modification of more chronic management. So we would treat patients according to their histological features and the clinical features like proteinuria and their GFR. International guidelines at the minute do exist, but they do vary across KDIGO and across the Paediatric Share Initiative and across the IPNA guidelines, although they're fairly similar, and I think this variation is just due to a lack of evidence. What we see in large real-world data, so this was a big European-wide study looking at 41 international centres and over 1,000 children, and looked at what we were currently doing to manage IgA vasculitis nephritis. And what we saw was that the majority of people were using immunosuppression, and most patients were receiving steroids together with another immunosuppressive agent, and this varied between MMF, azathioprine, cyclophosphamide or a calcineurin inhibitor, most people were using MMF together with steroids. And what they showed actually is that even with all of these different treatments on the real world data, the outcome was fairly similar. So I don't think there's any specific immunosuppressive agent that we would recommend for this condition, but I think general practice is to use immunosuppression to calm down the inflammatory aspects of this disease. So we know that for IgA vasculitis nephritis that there's a lack of evidence. There's been multiple Cochrane reviews now showing no significant changes in the evidence that's been coming and been published. And so at the minute they found no benefit to recommend any specific treatment. And our patients have felt this too. So this is a young lady who's now in her 30s who said that actually in 20 years nothing has changed for this condition, and she had kidney failure as a child and has had a transplant due to IgA vasculitis. So advances are coming. I think the international guidelines help raise awareness and attention and highlight the lack of evidence in this area, and initiatives like the adult IgA vasculitis working groups are really important to drive the field forward. We do see inclusion in some of the trials. So the pediatric EPIC trial looking at sparsentan did include in a basket approach patients with IgA vasculitis together with IgA nephropathy and Alport syndrome. And we'll also see coming through studies like the Pioneer study, which again will basket multiple autoimmune kidney diseases and includes this expanded population of patients with IgA vasculitis nephritis. We held a workshop earlier in the year to gather experts globally to see how we design a pathway to get really important pipeline of trials through for this condition. And I think what's really clear is that we need to move towards an age-inclusive approach so that we can include the children for the participant numbers, but also the adults to enrich that kidney failure outcome. And so it really is this kind of collaborative working across the ages that will allow us to open up this pathway to get better treatments for these patients. But what we saw from Augusto is the promising outcomes for B-cell depletion, and what we also know in the literature that both for vasculitis but also for IgA nephropathy, there are a number of treatments coming through that can immunomodulate pathways that might be very commonly shared with this condition. And we see trials in things like complement inhibitors and also APRIL BAFF inhibitors that might show promise in this condition, and we might be able to repurpose them from these other diseases across into this form of vasculitis. So we need to be able to stratify our patients. We need to know when we're actually going to intervene. So it might be that we can actually intervene at the very early stage and try and prevent nephritis. But at present, this seems to be very difficult, and we might not have the appropriate way to stratify patients just yet. But this is the area where biomarkers would be really exciting. We're currently focused on this area here to establish nephritis with the view to prevent CKD, but we know that there are new agents that are available like the SGLT2 inhibitors that might have a role in slowing the progression of CKD once we have established chronic disease. And as I mentioned, there are a number of different targets coming through the pipeline, which I think would be really important to push into this condition. So just to summarise, IgA vasculitis is commonly associated with nephritis. Children do have better outcomes, but it's a condition that we see much more commonly than our adult colleagues. Treatment at the minute relies on inhibition of the renin-angiotensin system, but also immunosuppression has a leading role to try and calm the disease activity. There is variation both in guidelines and in clinical practice, but that's likely due to the limited evidence, which we need to try and shift now. And the outcomes have not changed over time, which again is the priority focus. We do see advances coming, and I think now's the time when we're seeing lots of agents coming through, which gives us hope of improving the outcome for patients. Thank you.
Thank you very much, Louise.
Thanks, Louise.
And Augusto. We now move to the Q&A session. So we've got a first question from Nikolai Ulanov. It's directed to Professor Vaglio, but I think Louise also touches on this, so she might also comment on this. So the question is, do you think BAFF and APRIL and complement inhibitors may be potentially beneficial in IgAV, considering the results in the IgA nephropathy trials?
Louise, do you want to go first?
Yeah, I think when we held the international workshop, we looked at all of the different options, and these were coming through as really strong signals to be evaluating as the priority area. So targeting the B cell pathways, but particularly perhaps more specifically with BAFF/APRIL inhibitors that are now in phase 2 or early phase 3 trials for IgA nephropathy would be a priority area, together with the wealth of complement inhibitors that are coming through across the board. What we're now looking at is how we narrow them down to which actual agents we begin to evaluate, and how we do this at scale so that we can get a positive outcome. And that might start with just phase 2 trials to move them across into this disease, and then upscaling into phase 3 once we know which agents seem to be the most promising. So almost like a screening tool that allow us to then progress to a more substantial phase 3 trial. Thanks.
Yeah, I would like to answer in first of all in a general way. These are rational approaches. I think both B cells and complement are targets. I think, of course, that as it happens in IgA vasculitis, for instance, it might not be sufficient to target such a complex disease just with a complement inhibitor, whereas in my opinion, reiterated B cell targeting can be beneficial to control the disease, and we all know that BAFF modulating agents or APRIL modulating agents are very well tolerated, so they kind of qualify for also for long-term treatment of these patients. Right now, I don't know which their position is in the therapeutic armamentarium of patients with IgA vasculitis. I think that maybe the complement inhibitors can be more beneficial in patients that have a highly inflammatory biopsy, whereas B cells or B cell targeting agents can be across many different subsets, but this is just a personal feeling. I'm not sure. I think there's a question on this point also from Maria Sid, I see in the chat. Giorgio, you already looked at it, or?
Yeah, so if we consider 3 scenarios, one with skin-limited disease, one with moderate kidney disease severity, and one with severe kidney involvement, how would you treat these 3 patients?
Okay, can I go out of the room and think about? Because it's a very difficult question. I mean, I think if we have a disease with very low severity and the systemic disease is kind of weaning off, is going away spontaneously, you can also expect that your renal disease goes away spontaneously, and you can limit your treatment to whatever nephroprotection is, as like RAS inhibitors or other drugs. But this is common in children. I mean, I also see children, and I think Louise can share this approach. But in adults, you have to be more careful, and I think you have to rely on kidney biopsy as well as on the kidney presentation. So in these patients, the use of steroids or the use of cyclophosphamide or the use of rituximab or other agents, we also use mycophenolate a lot, is warranted.
Yeah. So I think for the children who have severe but skin-limited disease, they might have deep ulceration, we would definitely use steroids as first-line treatment. If we saw a child who had a persisting skin involvement, that might just be perhaps a petechial rash, but causing perhaps distress due to the visual appearances, particularly in the teenagers, we then might think of a more milder immunosuppressive agent, colchicine or hydroxychloroquine. And if it's not really shifting, sometimes we use MMF. But I think for the severe skin-limited disease where the skin integrity is broken, steroids really do still have a role to try and improve the kind of inflammatory status. For the moderate kidney involvement, I usually use steroids and MMF, and I try and use MMF to limit the time that we would use steroids. But I do know that some colleagues would just use a calcineurin inhibitor without any steroids, and they all seem to be equally effective. For a severe case, I think I'm more likely to add in rituximab together with the MMF and steroids. But actually in some children where they have rapidly progressive disease and they're on dialysis, I think still we would use cyclophosphamide like a kind of acute RPGN, I think you still need to stick to the drugs that we know. We would then move into the experimental phase, and there are compassionate use access to some of these agents if we're still seeing no improvement. And that's if we had a second biopsy and there was still inflammatory evidence and we'd exhausted all of the options that are used in more commonly, then we would approach the company for compassionate access. So I think that's when you're getting into the realms of our international experts, and those questions are often bounced around in forums or discussions to then get guidance, because those cases are usually quite small in number but quite severe in terms of the outcome.
There's also mention of plasma exchange. Do you have any experience?
I think there's very limited experience in adults, but I guess that most of us agree that refractory cases with rapidly progressive course or with life-threatening manifestations of the disease may be treated with plasma exchange. I can only recall one study which was mainly on crescentic forms of IgA nephropathy, which used plasma exchange on top of cyclophosphamide and glucocorticoids. And apparently this was a retrospective study, but it demonstrated that patients who treated with plasma exchange had some benefit as compared to those who only received glucocorticoids and cyclophosphamide. But we have to consider, as your work, Giorgio, is showing now, that patients with a crescentic form of IgA nephropathy are different from patients with IgA vasculitis related nephritis. They behave as two different diseases.
There is another question from Maria Sid about avacopan. She's aware of a small case series with avacopan. Are there more data available?
No, I don't think so. And I think, like Augusto said, they might be a group, perhaps those who have C3 on their kidney biopsy and the rest of their systemic manifestations have gone, who might benefit from complement inhibition. But it's still an unanswered question about the role of complement inhibition. And I think that fits into this bit when you've exhausted the other options of then you start to use these experimental options because you're on a pathway to kidney failure anyway. So I don't think there's any more data that I'm aware of to support individual drugs.
Maria, in France, we have gave to 5 patients in compassionate avacopan, but it's just the beginning, and we do not have any clinical data so far, but we will communicate it. A question for Louise and Augusto, apart the treatment, which is a major challenge in the next coming year. Do you think that there are other challenges to face in this field?
So can you say it again?
Yeah, apart from the treatment, which is a major challenge faced.
Okay.
Do you think there are other challenges to face in this disease?
Louise?
Yeah, I think, I mean, we know collectively as a group that we pulled out many of those challenges. That includes the lack of scoring the disease and also the adult classification. So I think moving the field on for adults is definitely the priority, because in the pediatric world we can't get these drugs to the patients without them coming through the adults first. I think the contrary to that is what our colleagues with IgA nephropathy are now seeing, is that you have a number of different drugs available and not knowing which one to use for which patient. So I think the accurate stratification of patients is going to become a challenge for all of the inflammatory kidney diseases. And it might be that this condition, we can start to plan that in advance because we're at this point of equipoise and point of kind of moving it forward, but we might be able to take that into mind and learn from the other conditions. So hopefully that's an opportunity that we'll have so many treatments. But I think the challenge is still in terms of classification, scoring, and trying to organise endpoints for this condition are there and real.
Well, in adults, I think that, but even in young adults, I mean, I think that the large variety of coexisting conditions, I would say, comorbidities, call them as you want, doesn't allow us to really understand what are the pure forms of IgA vasculitis, what are the secondary or associated forms. And I think this has some impact. So I think even understanding the disease is a little bit more difficult in adults than in children. So understanding if our approach has to be the same for all patients, I think this is different, and this can be a challenging point. And I think there is a comment from Tse Liang Go about just about the screening for cancer. Because the question is, how intensive do you care for cancer? For example, do you do cystoscopy given the rate of bladder cancer? Uh, I mean, we do not routinely recommend cystoscopy. We usually recommend age-appropriate screening for neoplastic diseases. But this has been a surprise from Aloysia's study that that they had such a large proportion of patients with bladder cancer. So I think a non-invasive screening like urine cytology can be worthwhile. Because it's, you know, the cost is low, it's non-invasive, it can be informative.
Thank you. I think the time is over. We have to conclude. So thank you so much for this beautiful talk to Augusto and Louise. Thanks to Giorgio to co-chair these sessions. So you have understand there's a lot of challenge to face. So if you are interested in working in this disease, do not hesitate. There's a lot of work to do, and you can contact the pediatric group or the adult group. See you. Wish you a pleasant afternoon, and see you soon. Giorgio, you want to add something?
Yeah, well, I think in a week time there will be another seminar launch. This is the Vasculitis Awareness Month, so always also issued by RITA and EUVAS. And also when you will leave the seminar, you will find a short survey that we will ask you to fill in. Thank you. Thanks to the speakers again.
Bye-bye.
Bye-bye.